Beautiful. So what is the idea? We understand first about how to preserve the tissue, how to do the design of the provisional, how the abutment can influence the tissue formation, about how to graft inside, how to position the biomaterial. So if you take this chance to preserve the tissue in the best way, the idea is to really have inside the socket a very strong peri-implant tissue. I believe the way we see this arrangement between the bone and the abutment, as you see now here on the evolution of these X-rays, probably this case is going to endure for many years comparing to what we usually have of peri-implant tissue formation. This is not even zero bone loss concept. This is building up tissue inside the socket once you understand. But not all the times you're going to have the chance to get the perfect socket to preserve it. And then you're going to start to talk about some deficient sites that I need to fix the phenotype, talk about the thickness. We're going to fix some recession, some soft tissue dehiscence, and some bone dehiscence on the immediate implant placement. Okay, so we're going to still finish this view, how to preserve the tissue, and then after the sequence we're going to try to rebuild on the immediate implant placement. After this first part, that is fresh socket treatment, we're going to go to deficient sites, talking about old implant with some aesthetic deficiencies, how to fix that, and after that we're going to go to elite sites, how to develop elite sites vertically or horizontally. So there is a sequence of reasoning line here. We stopped last day in this case, and one very important thing is not just environment inside the socket. I just comment with you guys, I don't know if I bring exactly the detail, but the biomaterial that you bring inside the socket, you bring a little bit more commonly than the bone crest level. But one important thing that this biomaterial cannot smash this soft tissue around. You're just going to bring like a cone inside, and the responsible to maintain that in place is stable is going to be really the provisional. When you bring the biomaterial a little bit higher in the socket, you're going to see that there is no space between the provisional and the biomaterial. When you take the provisional, some particles of the biomaterial is going to be exposed that you can easily remove that with a small curette. You can use sometimes a small collagen sponge or PRF interposed between them, but in the practical sense, there is not really much difference in the outcome later, and it's easier for you just to use the nice provisional on that. Okay, so let's bring one more case for us to maybe work with some details. I'm not going to really explain deeper the socket shield in this case, but a case that we use socket shield, we're going to still talk about the socket shield. And in this case, the nice part is going to be how to handle the impression in the digital workflow or analogic workflow to be precise when you achieve a very skeletal tissue with the anatomy of the papilla's emergence profile, and how to condition in this case. Because in a few cases you're going to have a small difference in the tissue formation, for less or for more, and I need to change this tissue. I need to design a zenith, I need to design a triangular shape. Sometimes I have too much tissue that I really need to push it up. And here in this case, you're going to start to understand how to do the conditioning stage for more than one crown, right? In the end of the day, you're going to get full arches condition as well. So this was a case that for me was a very rare and interesting case to treat it. This patient has internal reabsorption in basically most of the teeth in the mouth. There is a classification for internal reabsorption from 0 to 4 according to Hartzig. And in the class 4, you have completely compromised the tooth structure. You have so many different points of internal reabsorption that you already have necrosis of the canal. You have calcification of the entrance of the main canal here. You have sometimes some communication from the internal point for the external point, and patients start to feel pain on these tips, and you cannot treat it. You cannot access the canal, you cannot do surgery for this patient because it's so irregular, the points of reabsorption, that at the end of the day, the treatment is really extraction, right? In this case, the patient went to a clinic here, and the proposition of the treatment was extract all the arch, chop the bone to 114 and reduce it. My old technician, that now is a dentist, used to work in that clinic, and he brought the case for me for giving some, or to ask for some advice. And the idea was, instead of doing a FP3 case, why not to preserve the soft tissue and do at least a FP1 case? And I gave all the advice, we planned the case together, but the surgeon on that clinic was not feeling comfortable to do a FP1 case. His deal was really extract L14, and they brought the case to me for me to assist them on the treatment, right? And we recheck once again, now that the case was under my supervision, about which was the crown that was really necessary for us to extract. So instead of extract full arches, do all on 4 here in both arches, we just extracted from canine to canine, and there is one lower molar that we need to extract. All the other ones, we are really doing a long-term preservation. We're not sure how many years, but I think it's going to be better for the patient, do as really the needed for the treatment. You remember about the treatment plan for our patients, that when you're going to do a rehabilitation of the patient, you're going to do the surgery, first I need to think where is going to be the aesthetic part of the patient, right? In this patient here, when you redesign the incisal edge, you're going to redesign the incisal edge based on the aesthetic proportion of the patient, based on the lip at rest, based on the functional part. So the new incisal edge of the patient is going to be brought 1 millimeter, 1.5 millimeters lower. From this point here, we're going to establish the smile line curvature, following a parallelism with the lower lip to achieve this harmonic relation between the tooth position and the lip frame for the patient. And that is going to be the incisal edge for me to design, digital design, give this information for my technician. So my technician is going to be able to give me the provisional already according to the final treatment of our patient. Once we can measure that, really the technician can accomplish with precision the provisional design, okay? Or even the WhatsApp in case that you want to do a trying session for your patient. So we're going to increase not just the incisal edge, we're going to increase the width of this crown, being able to close the diastemas here, and we're going to try to push a little bit the gingival margin to achieve a proportion between width and length for this crown close to 80%. It's still going to be a little bit square-shaped tendons for these crowns here because you have long diastemas to close in this case, right? 6, teeth extraction, right? I know your faces, I know like the question, why 6 implants? But we are working for a second day now, and as I told you guys, the way we manage the peri-implanted tissue now, this is not a wrong decision. If it was some years ago, if you do not manage that, that was completely a complication that we are creating in our patient. But the way we manage and we develop the bone, especially interproximally, this is just an option of treatment that is very solid for your patient. And you're going to see even in the long-term result in the x-rays, how the bone was preserved between these implants. Really a beautiful case, right? Ricardo, I still don't like it. I want to do 3 implants. No problem. It's another option of treatment. We can work with Pontic if the same or similar result, right? In this case here, we decide to do unitary implants and develop as natural teeth here for the patient. We have also socket shield being done, a little bit different than traditional socket shield, we reduce a little more the thickness of the shield. Instead of being close to 2 millimeters, we reduce a little less than that. Very thin shield, close to 1 millimeter to reduce maybe any interference of the reabsorptions here. We're not sure how long this shield is going to stay there, if they're going to reabsorb or not. That's why we even use biomaterial inside the gap. It's not usual, right? The traditional socket shield is not necessary for you to use biomaterial inside the gap. And there is one of the root structure that reabsorption was really large that I need to take everything out and place the implants. Palatal approach. You see here I have a huge diastemas in this lateral incisor. We're going to return that. So my implant push a little bit against the distal bone peak for me to fix and to have the good distribution for this crown.
So
right?
This one, there was fenestration completely or not?
Here, yes, is a fenestration.
So you just pack the bone, you put anything buckle or just pack the bone?
One key point that you need to ask yourself when you are dealing with the essence, right? The material that you are putting inside that structure, or inside that wall, so inside this socket, is mechanically stable, or if you move something on the buccal side, you see some movement of the material. That is key point, right? To decide if you have done a good job or not, or if you need extra protection or extra mechanical stability. Once the material here is completely stable, then you have done your job, right? You have many different kinds of bone regeneration technique. Quarry plates, bone blocks, sausage technique. I can use maybe titanium mesh, I can use Teflon meshes, or whatever. And not all this technique, they completely isolate the bone from the soft tissue cells, right? For example, mesh. Titanium mesh full of holes. It's not isolating the cells. Why that work? Work because it's mechanically stable. Give the stability of the biomaterial. Sausage technique, according to the membrane that you are using, in a few weeks you have many points that the membrane is not there anymore. But at least give mechanical stability in the beginning. Does not matter the technique that you are using. If you do not fix that well, and if that moves, not going to work. Here, basically is the same. The biomaterial itself, being held in this small space, is going to be completely fine and is going to integrate it. But if by chance the essence is a little bit larger and you put the biomaterial there, there is movement, that is not going to work. Then I'm going to need some maneuver or some technique to promote this stabilization. I can use a membrane, I can use a bone plate, I can use RDI technique. There is many other things. You're going to discuss that in this sequence, right? But the key point or the key question is it stable? Yes. It's not moving? Yes. I can protect it? Yes. So be happy and don't worry about this, okay? Distribution, we're going to and then biomaterial inside the gap. As I told you, is not conventional for socket shield, but you know the reasons already. And you're going to have the same provisional done as we explained in the sequence. From the sealing zone, I'm going to have a concave emergence profile, all with biocompatible surface. In this case, we use pick abutment, customized one by one for sealing the socket and give a very long area that is biocompatible for the connective tissue to attach and protect the bone that is under. This was the end of the surgery.
How long did it take you to make all the abutments?
In that day, I brought my old technician was with me here, helped me to realign the provisional, but usually every abutment is going to take at least 15 minutes for you to realign the abutment, plus 10 minutes for you to work with the provisional. It means 25 minutes each, so it's a long time, but you just do that once. And the nice part was I doing surgery, fix one implant, he was already realigned, we worked together, right? So that was nice. I finished the surgery, maybe total time here, a little bit under 3 hours.
How
It's a
did
long
you
time,
create
but
the
it's-
model?
Sorry?
How did you create the model?
Here was a scanning. We scanned this model and to create the provisionals. So this helped to position the provisional, realign the provision because we have even the guide of silicone.
So you scanned inside the surgery and printed the model, or did
No,
you
this was pre-done.
pre-done? Okay.
Yes, okay. Nice. So we start the day or the morning with this arrangement, and you finish the morning with the new provisional over the implant. All the implant between 50 to 6 newtons of torque, a good implant. If you have any doubt about the primary stability here, you can just connect to the grounds, increasing the stability. This is not a patient that has any bruxism, but even though we have impression after that, and 3-4 days later we have some night guard. Why is that? The problem is not the centric position. The problem is lateral anterior movement, especially when the patient is sleeping.
I have a question. When I used to do the emergency profile of the bone and I put the collagen plastic. Most of the time, I see that it's pushed back up. So, but sometimes when I have to hack the plug, but I feel like the gum is.
And you see
the
the part
is gonna maintain or it's gonna lose it.
The particles of the biomaterial is pushing the material, or the collagen plug that you put inside is starting.
Because I put the kind of the plug in the abutment,
Okay.
and I pack, and the bone is there.
So I'm going to tell you something. I do not use so much plugs because you cannot be precise the way you cut it, and you have the biomaterial, then you bring the abutment. Sometimes you push away, you give compression on the margin. And a good sealing zone, it's a balance between gives mechanical support without compression, and sometimes at the PRF compress the tissue, push the tissue aside, and it's going to take this place. And then you need to turn the PRF in the new tissue that you already had it in place. So I prefer to really do the sealing zone on provisional and put nothing under. So the arrangement is better than really try something else. 7 days later, a little bit unconventional healing. I have the tissue growing up here, and a small recession in the first 7 days here on the lateral incisor. But 3 months later, with the total healing here on the time of the impression, you can see on the CBCT scan the position of the implant. But what happened 3 months later? I have all the tissue with this thick phenotype, socket shield, everything done, a little bit of the growth of the soft tissue over the crown. Once again, I have square-shaped crowns. Improve a lot. Improve the functional part of the patient, improve the aesthetic, but it's going to be nicer to have a little bit longer crown. How to do the job now? Conditioning stage, right? According to how much I need to push the gingiva, I can just modify the emergence profile, just modify the critical area position, move the tissue, and redesign the margin once again.
What's the temporary material again?
This is PMA. If you're going to get the same treatment plan from the beginning and apply that, you're going to see that I have extra gingiva for 1.4 millimeters, 1.5 that I need to redesign. The question is how to condition that. If you're going to try to do that straight in the mouth of the patient, this is completely crazy process because you do not control, you're not precise, you take one provisional, you add some composite, then you need to push back, smashing the gingiva to check. Oh, need to add more, then you add more 50 minutes, then it's too much. You not control the process. So how to control and how not to have a stressful job, right? Because you already have so many points in our job that is stressful. If you add one more technique that is stressful, it's not going to be a nice day. So the idea is to enjoy what we're doing. To be precise, if you can control the process, then no stress involved. What I'm going to do here, we're going to make an impression with alginate, okay, when still the crowns are screw retained. So you do a regular impression of alginate, move it out the impression. Then I'm going to unscrew the provisionals one by one, and I'm going to connect the provisionals to the analogs. Then I'm going to move this provisional with analog inside the impression tray, and I'm going to produce a cast. But I cannot use a plaster material, gypsum, because that is going to take like 45 minutes to 1 hour. I don't like to have tissue that I really create with very good papilla, nice socket, and that this tissue without any support. If you take this provisional for sometimes 10, 15 minutes, the gingiva already start to change. If you let that 1 hour, you have completely this tissue melted down. You try to move back the provisional, it's painful for the patient, you compress the tissue. So all the time, the tissue that I create, I need to give some support for this tissue, right? So first thing, I'm not going to have the provisional for long outside the mouth. That's why we choose to use a silicone material. This silicone is really made for casting. It's a dye silicone. People that does indirect restorative work using this kind of silicone, and this silicone sets in 3 minutes. So you start to pour inside the impression tray, 3 minutes later is hard enough for you to pull it out. Total time that the provision is going to stay outside the mouth of the patient is going to be between 6 to 8 minutes. Fast enough for you to pull it back without the patient feel uncomfortable. Then what I'm going to do? Last day we discussed about crown lengthening, do you remember? Yeah, we're going to use something very similar to the steps of crown lengthening, but I'm going to modify the tissue contour on the cast. I'm going to take one measure from one of the tooth before take it out. Why is that, Ricardo? Because I'm going to have the calibration of my rule here, or I'm going to know exactly that the tooth being 9 millimeters and I need to add plus 1.5 millimeters. On the cast, before removing the provisional, I get the same caliper and I'm going to measure the 9 plus 1.5 millimeters and I'm going to make a mark on the silicone border. It's like crown length, the same thing that we have done last day. So these are the marks, right? How to change this tissue. I'm going to bring the sealing zone or the critical area straight down as we discussed last day, and from this vertical modification of the gingiva, how is the shape of the inside the socket, the transition zone, concave, as concave as possible without being retentive, what is going to give you more or less 45 degrees of inclination, right? So see, let's look here how we modify the cast. The nice part is that patient is taking a nap, you are working on the cast, listening to some music, relax, because this is an easy job. It's nice for you to do that. You see the zenith position, triangular shape, from here, concave. This is going to be the base for me to modify the provisional. Remember, last day I showed one very fast case that I have a similar cast. I took the provisional, you have the gap, and you fill the gap, right? How long take you guys to modify one crown? Maybe 20 minutes, not more than that. 4 crowns is 40 minutes, 45 minutes. Once again, if you do everything with the provisionals, taking the provisionals from the mouth, it's almost 45 minutes that the tissue eats alone and is going to collapse. So to solve this technical problem, to remove the provisional and still give support of the tissue, you know what we do? Over this cast, before bringing the provisional to this cast, we bring impression posts. We connect the impression posts here, and one by one, you're going to add flowable composite, pattern resin, any hard, any stable material. So I just connect that, and here in this case we are using GC paternal resin. I like to use that, I really enjoy to use. But nowadays you can use even this similar material that you can make photopolymerization, making this job fast and easy. Then 5 minutes and you have that ready. What this is going to be used? When I remove one provision from patient's mouth and put it one impression post, the impression post are really going to move the gingiva from the position. All the rest of the socket is perfect. The compression is just 1.5 millimeters here. Most of the patient from this amount of condition does not even complain about the compression. If it's more than that, or if your patient is a little more sensitive, you need to give anesthesia for the patient. Okay, nice. And these impression posts also, at the end of the conditioning stage, if the gingiva does not change, you can use for final impression in analogical workflow. So let's look again. Take it out, straight away put the impression post. It's beautiful because you see the modification of the margin exactly as we had planning before. 1.5 millimeters, triangular shape, zenith more distally, super in the control, no stress. Take it out, take another one. I'm going to do that with the 4 incisors, and I'm going to bring the 4 incisors outside the mouth. Now, once again, what I need to do, drink a coffee, listen to some music, patient is taking a nap, and you're going to have maybe half an hour, 40 minutes to modify this crown, adding in the gap here the acrylic necessary. Okay, so we're going to add the acrylic or the material that you like. If you like to work with flowable, according to the material base, sometimes one and another we have as option. What I need to do now, take the impression post out and one by one bring the crowns in. New shape, 1.5 millimeters, triangular shape, new proportion. I left that in place for this small condition for 2 to 3 weeks. Very rare the gingiva change. But in a few cases, if the gingiva has a little bit super thick phenotype, that sometimes you graft it too much, maybe the gingiva is going to grow over the crown again. Then I need to fix that with a chirurgical procedure, but we're going to tell how to do the job, okay? Because in the prothetical management, there is not necessary for you to do anything else. Usually the gingiva is there. So what I'm going to do now, impression. How is the best way for me to do a good impression here? Analogical workflow, the answer is here. Everything is there, right? Just connect this in the position and you have a very good impression with silicone, with a customized impression tray. If I want to use a scanner, if I want to do a scanner, what I need to do? I need to copy and paste the provisional design. The provisional design is the key point for you to have the right information for your technician. So I'm going to have three scanners here. First, with the provisional still in the mouth, is screw retained. Nice. Okay. So I'm going to have the shape of the provisional, the shape of the tissue around the area, palatal buccal. I'm going to remove the provisional, have the scan body in position. Then I'm going to scan again. The weak point about this scanning is the subgingival contour here on the socket. There you have distortion. If you have distortion in this image here, your new crown, your new abutment is not going to be fit in the place. It's going to be gap, it's going to be over compression, and you're going to lose the control. You need to adapt it too much, adjust too much, send back for the lab. What they want, receive a job or receive a work that is really precise. Our provisional is almost perfect. It's a prototype. I want to copy it. Okay, I know the shape of the provisional outside the crown, but here, what I'm going to do, I'm going to scan the provision outside the mouth, one by one. I know that is a lot of work, and I need to merge the image. Why is that? When I merge the three images, position the scan of the crown outside, inside this image, you're going to have the precision of the subgingival contour. So your technician just need to copy and paste this shape. It's going to be very easy for him to deliver.
Which software do you use to merge?
Uh,
Which software do you use to merge these two files?
Depends on the technician now, because I do not do this. I do not merge the image. I send the scan for the technician, and they're going to merge the image according to the software they use and whatever, right? Nice. So this is a simulation, just the scanning of the soft tissue, the position of the crown, and here you have the abutment in yellow being designed exactly as the provisional design. Exactly as the provisional. So if they want to modify something, for example, in one of the canines, I ask for compress a little bit the margin of the canine. And he's going to give a abutment with the sealing zone here, or the critical zone, 1 millimeter up to try to push a little more the gingiva. So we are in the control. But one interesting fact here is the distortion. In pink is the scanning with the scan body. In white and yellow is really the shape of the gingiva done by the provisionals, right? So 1.7 millimeters of distortion. I'm just going to close this window because of the noise, and we're going to let the other one open. Okay. So the abutments, zirconia over tie base, all biocompatible from the margin down. Then I have the crowns done, so you know the deal, how to do this workflow. And on the day of the delivery, when I fit one of the crown, no compression, no gap, no pain, no adjustment. Another lateral incisors, no problem at all. Look at the relation between the finals and the architecture of the tissue. So the nice part is like, there is not much to think. There is not surprise. There is not adjustment. So when I started to really understand how to copy and paste the provisional design and give this information right for my technician, the prosthetical part really, I enjoy to do that. I used to enjoy a lot because nowadays I focus much more on the surgery, but that is a good way for you to not have stress on the workflow. There's no surprise because you really control all the steps, right? So this is the final arrangement, lateral view, the front view, beautiful architecture here, completely preserved. I think much better than our own 4, right? And this is a nice picture, but the beautiful view for me is on the x-rays. So I told you that, okay, with the right philosophy of dealing with the fresh socket, we not just preserve the bone, we develop the bone inside. If you see the relation between the bone and the abutments here on the thigh base or even the zirconia area, with the bone, we not even mention the level of the bone around the implant caudiform, because it's not around the implant caudiform, it's over. So this relation is beautiful for us to see. So that's why I make possible you make 6 implants, 1 close to each other, because really it's something that you can reproduce in daily basis if you adopt the same work.
Have you had any problem with the small particles of the one that are in the sulcus? Sometimes.